I want to start today with a data point from the reading that genuinely stopped me in my tracks.
Yeah.
Usually when we're looking at public health numbers, especially around addiction, you're sort of bracing for impact.
Expect bad news.
You expect the trend lines to be grim, but this was different.
That's the kind of statistic you have to read twice, just to make sure it's not a typo.
Between 2023 and 2024, drug overdose deaths in the U.S. dropped by nearly 27%.
It's huge.
That is the largest annual decrease we have seen in 3 decades. And after years of headlines just getting darker and darker, seeing a drop of that magnitude, it just forces you to stop and ask, what changed? What are we finally doing right?
It's a massive shift. And the answer isn't some, sudden miracle cure.
Right.
It's a combination of things: expanded access to medication, widespread naloxone distribution, and just a fundamental shift in how we even view treatment.
Moving away from the one-size-fits-all idea.
Exactly.
Yeah.
Something much more sophisticated now.
And that is our mission for this deep dive. We are unpacking the July, August, September 2025 issue of the Carlot Addiction Treatment Report. We're going to look at the nuts and bolts of how addiction treatment has evolved.
From the chemistry to the conversation.
Exactly. From new injectable drugs to the very specific psychology of how you talk to a patient.
Right. Because it's not just rehab anymore. It's this complex mix of biology and psychology, and knowing which lever to pull it's the difference between life and death.
So to keep this all grounded, I want to use a specific case study they use in the report. They introduce a persona named Carla.
Carla's a great anchor for this discussion.
So let's set the scene. Carla is 38. She's been using opioids for about 10 years. For a long time, she was what you'd call functioning.
Holding down a job, family obligations, all that.
But recently, things have escalated. She's struggling. She's never had treatment before. And she walks into your office and asks the million-dollar question: should I start medication or do I just need therapy?
That is the classic question. And honestly, maybe 10 or 20 years ago, the answer would have just depended on the philosophy of the doctor she happened to see.
Right. You'd have the medication is a crutch camp over here.
And the therapy doesn't work for addiction camp over there, yeah.
Fighting it out.
Precisely. But today, we don't have to guess. We have data. And to answer Carla, we need to look at what the report calls the SUD treatment continuum.
SUD being substance use disorder.
Correct. So imagine a horizontal line. On the far left, you have medication.
Okay.
And on the far right, you have psychotherapy. Where a patient falls on that line isn't a matter of opinion. It depends almost entirely on what substance they're using.
So let's apply this to Carla. She's coming in with opioid use disorder. Based on the reading, she lands firmly on the left side of that spectrum.
She does. For opioids, medication is the cornerstone.
And I think this is where a lot of people get stuck. There's this stigma that giving someone methadone or buprenorphine is just, trading one addiction for another.
A very persistent myth.
But the report has some aggressive data on why this is the standard of care. It's not just about stopping the high.
No, it's so much deeper than that. The data shows that these medications like methadone and buprenorphine, they're associated with significantly lower rates of suicide, cancer, cardiovascular disease, all-cause mortality.
The cancer link was the one that really stood out to me. Preventing overdoses, that's obvious. But cancer, that suggests these drugs are fundamentally changing the body's physiology.
That's a great observation. Think about the biological stress of addiction, that constant cycle of withdrawal and intoxication. It just creates chaos in the body.
Inflammation, stress hormones.
All of it. Neglect of health. So when you stabilize that chaos with medication, the body can actually start to repair itself. You aren't just preventing an overdose, you're preventing the systemic breakdown that links to things like heart disease and cancer.
So for Carla, the answer is clear. We start with meds. We stabilize the biology first. Okay, but let's flip the script. Let's say Carla walks in, but she's not using opioids. She's dealing with a stimulant addiction cocaine, or meth. The report suggests we slide all the way to the other end of that continuum.
We do. And this is, frankly, one of the frustrating realities of addiction medicine right now. For stimulant use disorder, we just don't have a medication that works the way methadone does for opioids.
There's no FDA-approved replacement drug.
Not yet. The report mentions some off-label attempts, things like topiramate or a combination of bupropion and naltrexone, but it calls the benefits modest.
And modest feels like a very polite way of saying they don't really work that well.
Not consistently enough to be the primary treatment? No. So for stimulants, the gold standard is behavioral. specifically something called contingency management.
I found this fascinating. It really challenges our whole idea of therapy. This isn't sitting on a couch talking about your childhood.
Not
Well,
a,
essentially paying people to stay sober.
that's the blunt way to put it, yes. You incentivize abstinence, the patient gives a urine sample, and if it's negative for stimulants, they get an immediate reward, often cash.
It sounds so transactional, almost like bribery. But when you think about the biology, it makes perfect sense. We're hacking the dopamine system, right?
You've hit the nail on the head. A brain on stimulants has been rewired to seek these massive, immediate dopamine rewards. Talk therapy, as valuable as it is, doesn't provide that immediate neurochemical hit.
But a $20 bill does.
A cash reward absolutely competes with the drug on a neural level.
Yeah.
You're introducing a competing dopamine source. It leverages the exact same reward mechanism the addiction uses.
And the data shows it's highly effective.
Very. The problem, as you can imagine, is funding.
I was just about to say, I can't imagine insurance companies are thrilled about handing out cash to patients.
They get very squeamish. It's a political hurdle, even though the data shows it saves money in the long run by keeping people out of the emergency room.
So we have opioids on one end, meds first, stimulants on the other, behavior first. And then you have the legal substances, alcohol and tobacco, kind of sitting in the middle.
Right. For those, we often use a mix of both.
I noticed for tobacco, the report was very specific about varenicline, which most people know as Chantix. There's been a lot of debate about that drug over the years, especially with mental health side effects.
There has been. Historically, there was a big concern it could worsen mood or even increase suicidal ideation.
But that's been debunked.
The report clarifies that the most recent data suggests it is safe, and it remains the most effective option, even for patients who also have depression.
They also touched on e-cigarettes, on vaping. And it felt like the report was walking a tightrope there, calling it a double-edged sword.
And it is a delicate balance. On one hand, from a pure harm reduction standpoint, vaping is almost certainly safer than lighting tobacco on fire and inhaling smoke.
You're cutting out a lot of the carcinogens.
But you're not treating the addiction itself, you're just changing the delivery method for the nicotine.
Right. So patients often just swap the cigarette for the vape. They aren't getting sober in the chemical sense.
Precisely. They're just maintaining their nicotine levels more cleanly. It's better than lung cancer, absolutely, but it's not a cure for the dependence.
So we've established a medical strategy. If it's Carla with opioids, we want meds. If it's stimulants, we want incentives. But regardless of where she is on that line, you eventually have to actually talk to her.
You have to navigate the human element, and that brings us to the psychology of change.
The report focuses heavily on motivational interviewing, or MI. Now, I think a lot of people, myself included, often confuse MI with just being nice or trying to convince someone to quit.
That's a really common misconception. The expert they interviewed, Dr. Steve Martino, is very clear. MI is not about installing motivation into a patient.
It's about mining it out of them.
Exactly. Because if you try to convince someone of something,
The natural human reaction is to push back. It's like Newton's third law of arguments.
it really is.
Mm-hmm.
If I tell Carla, you have to stop using, it's ruining your life, what is she going to do? She will instinctively start listing all the reasons why she can't or why it's not so bad.
Which the report calls sustained talk.
Right. It helps my anxiety. It stops the withdrawal. I can't face my job without it. The more she says that stuff, the more she believes it.
So the goal of MI is to flip that script. You want to elicit change talk.
You want Carla to be the one saying, I want to get my kids back, or I'm tired of being sick. The clinician's job is to create an environment where the patient talks themselves into changing.
The report lays out this framework called PACE. Partnership, acceptance, compassion, and empowerment. But I want to look at a specific tool they mentioned. Ask. Offer. Ask.
A very practical tool.
It seems like a great way to avoid that lecture trap.
It is. Let's play it out with Carla. Say she's hesitant about taking the buprenorphine we recommended.
Okay.
A traditional doctor might just lecture her about pharmacology.
But using ask, offer, ask, I start by asking. Carla, what have you heard about buprenorphine?
Perfect. And maybe she says, I heard it's just liquid handcuffs, that it's impossible to get off of.
Then I make the offer. I might say, that's a valid concern a lot of people have. The science actually shows it stabilizes the brain so you can function again rather than just getting you high. And we can taper it slowly when you're ready.
And then, the crucial final step.
Mm-hmm.
You ask Kay again.
How does that sound to you?
Yes. You're constantly throwing the ball back into her court. It keeps the autonomy with her. It respects her intelligence. And that respect is often what lowers the defenses enough for the actual data to get through.
It's like psychological judo. You're using their own momentum. Now, speaking of support, we have to talk about the elephant in the room of addiction recovery.
Alcoholics Anonymous, the 12 steps.
It's the most well-known recovery brand in the world. But is it clinical treatment? If I go to a church basement for a meeting, am I getting therapy?
Technically, no. AA is a mutual help group. It's peer support. However, the report discusses a clinical therapy called 12-step facilitation, or TSF.
So TSF is the bridge
Hmm.
between the clinic and the church basement.
That's a good way to frame it. TSF is a structured therapy designed to encourage patients to attend AA and, maybe more importantly, to help them engage with it.
Because the dropout rate is high, right? People go once, feel awkward.
And never go back. TSF coaches them through that initial friction.
And the data on this was surprisingly strong.
It was. Dr. Joseph Nowinski cites research showing TSF was actually superior to CBT.
Cognitive behavioral therapy.
So alcohol abstinence over a 3-year period.
Wow. That is a bold claim. I mean, CBT is the gold standard for almost everything in mental health. Why does TSF win out here?
It likely comes down to the social component.
Yeah.
CBT happens in an office 1 hour a week. TSF connects you to a fellowship that exists 24/7.
So when you're craving a drink at 10 p.m. on a Tuesday, your CBT therapist isn't available.
But your sponsor is. It outsources the support structure to the community.
That makes total sense.
And TSF isn't just go to a meeting. It involves specific electives or recovery tasks. The one that stood out to me was the genogram.
Right, mapping out the family tree of addiction.
You sit down with the patient and you literally map out the history of addiction in their family.
Mm-hmm.
It visualizes the genetic legacy. It helps the patient see that this isn't just a personal moral failing.
It's a biological pattern they inherited.
Exactly.
That has to be incredibly de-shaming for a patient. It shifts the narrative from I am bad to I am fighting a family curse.
And that shift in perspective is often necessary for recovery to even begin.
Okay, I want to circle back to the biology for our final segment. We established early on that for Carla, our opioid patient medication is key. But the report details a specific hardware upgrade in that department, a drug called Brixadi.
This is a new formulation of long-acting injectable buprenorphine, an LAI.
Now, we've had injectable buprenorphine before, Sublocade. Is this just a rebrand, or is there a functional difference?
It's a functional upgrade. Think of it like version 2.0. A few things are different. It stores at room temperature, which is a big deal for clinics, and it uses a thinner needle. Sublocade uses a 19-gauge needle. Brixadi uses a 23-gauge.
And just so we're clear, in needle terms, the higher the number, the thinner the needle.
Correct. So 23 is significantly less painful than 19.
But that's not the real headline here.
No. The real game changer isn't the needle size, it's the rapid induction capability.
Okay, this gets a bit technical, but let's unpack it because the stakes are high. Usually to start buprenorphine, a patient has to be in withdrawal, right?
Yes. This is to avoid something called precipitated withdrawal.
Which happens if you take it too soon.
Right. If you still have opioids like fentanyl on your brain's receptors and you take buprenorphine, the buprenorphine rips those other opioids off the receptors aggressively.
And because buprenorphine is only a partial agonist, it doesn't activate the receptor fully. So the patient goes from high to zero almost instantly.
Exactly. It sends them into an instant, maximum intensity withdrawal. People describe it as the worst flu of your life times 10, happening in seconds.
And that fear is a massive barrier. People can't bear the thought of waiting 24 or 48 hours to get sick enough to take the medicine safely.
But the report details a study by D'Onofrio and her colleagues using the weekly Brixadi shot. Because of how it releases into the bloodstream, slower, more controlled, they found you can give it even when a patient is in only mild withdrawal.
So you don't have to wait for the full-blown sickness.
You don't. They did this in the ER. Only 7% of patients experienced that precipitated withdrawal. But here's the number that matters. 7 days later, 73% of those patients were still engaged in treatment.
73% retention from an ER population, that's incredible.
It's a logistical victory. By removing that waiting game, you capture the patient at the exact moment they ask for help. Carla walks into the ER, and instead of saying, wait here and get sick, you can give her a shot that buys her a week of stability right then and there.
When you put all these pieces together, that 27% drop in overdose deaths, it starts to make sense. It's not just one thing.
No. It's the culmination of better tools and better systems. We have expanded access to naloxone. We have smarter medications like Brixadi. We have psychological frameworks like MI that actually respect the patient's autonomy.
And we're moving toward a model that treats addiction more like a logistical and biological puzzle and less like a sin to be punished.
That seems to be the key. We're matching the right tool to the right person at the right time. If you give a methadone patient just a pep talk, they might fail. But if you align the treatment with the specific disorder, you get results. You save nearly 30,000 lives in a single year.
And that's the big takeaway for me. We often think of recovery as this movie moment of pure willpower.
Right.
But the data suggests it's actually a series of small, smart decisions about chemistry and conversation.
Absolutely. The toolbox is just fuller than it has ever been.
It leaves me thinking, if we can make a dent in a problem as impossible as the opioid crisis just by refining our tools and listening to the data, what other unsolvable problems are just one hardware upgrade or one better conversation away from being fixed?
Yeah, that's a fascinating question.
Something to think about. Thanks for diving in with us.
My pleasure.
We'll see you next time on The Deep Dive.